Welcome to The Scoop, NANP's monthly Hot Topics educational webinar series. I'm Shannon Montoya, and I want to first remind you of a few things before we get started. These calls are recorded to listen to again at your availability on the nanp.org website. And to thank those who registered, you'll receive a link to the recording of the webinars that will be sent to all registrants within the next 24 hours. I'd like to invite you to look for the Scoop webinar invitations in the Nourishing Bites e-zine early in the month so you don't miss any of our informative presentations, and be sure to join our Facebook page so you don't miss out on important updates. I'd also like to invite you to share your hot educational topic with NANP. Are you doing great work in clinical research? Do you have expertise in business or legislation matters and would like to share your experiences? NANP wants to highlight all that speaks to our nutrition professional community. And NANP now offers the Scoop webinar for continuing education. You can earn 1 continuing education credit when you participate in the Scoop and take the corresponding quiz. You can find out more by going to nanp.org and check out continuing education. You can also contact me, Shannon, at nanp.org for other inquiries. Today's webinar will conclude with a question and answer session, so please feel free to type in your questions throughout the webinar so we can get to as many as possible. So let's get started. Today, our guest is Dr. David Brady, a Connecticut licensed naturopathic physician, certified clinical nutritionist, and a diplomat of the American Clinical Board of Nutrition. He is presently the Vice President of Health Sciences, the Director of Human Nutrition, and an Associate Professor of Clinical Sciences at the University of Bridgeport in Connecticut. Dr. Brady has also lectured extensively on the international postgraduate speaking circuit for over 18 years and has appeared on the panel of numerous major scientific conferences in the field of nutrition and integrative medicine. Dr. Brady has maintained a private practice since 1991 and currently practices in Connecticut, where he specializes in functional and integrative medicine, clinical nutrition, and the natural management of internal disorders such as chronic fatigue syndrome, fibromyalgia, and other disorders of the system. We're so pleased to have you here with us today, Dr. Brady, to share your influence and experience on the integrative management of fibromyalgia and chronic fatigue syndromes. Thanks for joining us.
Thank you very much. I appreciate it, Shannon, and really appreciate NANP on having me on your wonderful webinar series. And I have the pleasure today to talk about a clinical topic that's one of the focuses, certainly not the only focus, but one of the primary focuses of my career in practice, in academia and research, and in publishing as well, which is global pain and fatigue syndromes. And much of what I'm going to be outlining is really a culmination of about 25 years of grappling with this topic. And it culminated recently, or in July, in the publication of my book, The Fibro Fix. And I'm going to be able to go a little bit deeper into some things with a practitioner audience today. And I hope you find it useful in how you conceptualize and deal with the patients who come in who may have this diagnostic label and may have actually this complex disorder we call classic fibromyalgia. You went through my bio, so I will not, I'll not bother to go into that anymore, other than to list my disclosures as appropriate. And in addition to my academic appointment and my clinical practice, just as a matter of disclosure, I am the Chief Medical Officer of Designs for Health, a nutraceutical company for the professional market. I'm also the Chief Medical Officer of Diagnostic Solutions Laboratory, a molecular GI microbiome mapping focused laboratory, and a consultant to Cell Science Systems Laboratories, or ALCAT Labs. So let's talk about this thing, fibromyalgia. It is a point of a lot of frustration, not only for patients as they try to deal with this themselves and try to deal with healthcare providers who are often ill-equipped to really help them and understand their plight. And it's very frustrating to healthcare clinicians, whether they're physicians, whether they're nutritionists, whether they're some sort of body worker. It doesn't really matter what they are. If they're coming into contact with these patients, it's often a very frustrating endeavor because the clinician feels like they don't have great answers. They don't generally get good results. And particularly speaking from the standpoint of physicians, particularly orthodox physicians, they really do not enjoy these patients. These are the patients they see on their schedule and they go, oh no, she's coming in again and I'm not sure what to do for them. So what I want to do is try to reframe this and change this whole sort of vibe so that the clinician and the patient has a much different experience. And to first start understanding this, you have to understand that true classic fibromyalgia and fibromyalgia diagnosis in general is strongly predominantly a female disorder. Over 90% of the diagnoses, and over 95% of the correct diagnoses are actually in women. And we're going to talk about some of the hypotheses on why women are so much more afflicted with this condition than men. We don't know for sure, but there are certainly some pretty decent hypotheses on why it occurs. But the major risk factors are simply being female and getting older. You can see that most of these patients are not only female, but they're generally somewhere between the age of 30 and 60, but predominantly 35 and 55, if you really want to narrow it down statistically, or 35 and 60, somewhere around there. And this has created a problem in that many of these symptoms that the patient has are not organically identifiable on laboratory testing, on imaging, and on other ways that doctors are trained to find problems in disease. And since it's predominantly a woman's disorder, and at least historically, this has changed tremendously over the last 20 years, but historically before, when the whole sort of almost the mindset or the perception of fibromyalgia in the healthcare community was established, it was really a male-dominated physician and healthcare workforce where, there was a disconnect. And often I think that was getting in the way. And often these patients, unfortunately, were labeled as hypochondriacs, just making it all up. It's all in their head. Therefore, they must just have a psychological disorder and they need meds, right? So they ended up being referred out to psychiatrists and they get put on various forms of meds used in more psychology applications, antidepressants and antipsychotics and anxiolytics and you name it, they get put on them somewhere along the line. Now, this has been definitely evolving over time, but some of that stuff still sort of lingers and hangs around, and it even pervades some of the attitude of new physicians as they get out of training. And what's so difficult about this, and it's difficult for patients to understand this, but it's very difficult for health providers to understand this as well, that fibromyalgia is not a muscle disorder. It is not a body somatic tissue disorder. The name fibromyalgia simply implies fibro, the soft, compliant, stretchy tissues, muscles, tendons, ligaments, fascia, and not the bone, not the joints. So it's not a joint problem. It's not a bone problem. So they're talking about these stretchy, compliant tissues when they say fibro. When they say algia, it simply means pain. So it means pain in those types of tissues, muscle, tendons, ligaments, fascia, or at least perceived in those tissues. So the logical conclusion to jump to is there's a problem in those tissues, right? There must be inflammation. And that's not the case in true classic fibromyalgia. In fact, the patient may perceive achiness or pain in those types of tissues in the body, but when you really drill down and look, there's no actual problem in those tissues. The problem instead is centrally located. It's in the central nervous system. It's in the brain. It's in the spinal cord. It's a perceptual issue of pain rather than an organic cause of pain in the peripheral tissue. Now, if that is true, you would expect that you would have a whole constellation of centrally mediated problems or symptoms associated with it, and that's exactly what we have. We have things like irritable bowel syndrome, depression, anxiety, sleep disorder, hypervigilance, and other things that you would never find associated with just a muscle problem, right? So it doesn't make sense that a problem in the muscles would cause depression, anxiety, sleep disturbance, irritable bowel syndrome, and cognitive dysfunction, significant fatigue. But it does make sense if you look at it from the standpoint of a central sensitivity syndrome. Now, there have been many proposed etiologies through the years, and I don't really have time to get into every single one in granularity, but a lot of things were looked at. And initially, a lot of the things that were looked at were pathogens, mainly viruses, not only overt but stealth viruses, EBV, CMV, HSV, you name it, various viruses were looked at. And some of that was because of the initial connections between chronic fatigue syndrome and fibromyalgia. We know that chronic fatigue syndrome very often follows or is a sequela to a acute viral flu-like illness where there's a viral situation, it resolves overtly, but the lingering stealth infection with that virus can cause persistent fatigue and immune dysfunction. And sometimes they refer to chronic fatigue syndrome or CFS as CFIDS, chronic fatigue and immune deficiency syndrome. Since fibromyalgia also has along with it long-term persistent fatigue or chronic fatigue as a symptom, if you will, they were lumped together originally. Therefore, some of the same things that were being studied related to chronic fatigue syndrome etiology were studied as it related to fibromyalgia. However, I want to make something very clear on this call. Chronic fatigue syndrome is not the same as fibromyalgia, and they should not be talked about in the same breath. So often you'll hear or you'll see things written fibromyalgia/chronic fatigue syndrome /fibromyalgia. That's a holdover from 20 or 30 years ago that really the research has clearly defined these are different entities. They have vastly different diagnostic criteria, so they really should be dealt with separately and not in some sort of lumped together fashion. But it turned out that in fibromyalgia, chronic viral infection, stealth infection with viruses, does not seem to be the etiology that's causing this central pain processing and central sensitivity syndrome. We do know that there's aberrant levels of key neurotransmitters in these patients, including serotonin, norepinephrine, substance P, a pain-modulating peptide, which we'll discuss, melatonin, the catecholamines in general, and we'll look at what some of those things mean. But we do not know yet that they are causal. They simply may be the effects of the disorder. Hormones, thyroid, adrenal, growth hormone, has all been looked at, and they all have connections to fibromyalgia, but they are not the prime etiology of true classic fibromyalgia. They're often points of misdiagnosis, but they're not actually the cause of fibromyalgia. Sleep disorders we're going to look at specifically as it relates to fibromyalgia. Once again, though, is it causal or is it an effect? We'll look at that question. Psychological issues. We're going to look at stressors, issues of post-traumatic stress, adverse life events, particularly in early life, and what role they may play. And there are many other things that we'll touch on that are more functional metabolic, from mitochondrial ATP production, cumulative toxic loads, other types of things that are really not fibromyalgia. They're just points of confusion because they can create a lot of symptoms that make it look like a person may have fibromyalgia. Now, I know the bulk of the listeners are probably nutritionists and not physicians. We probably have some physicians on the line as well. So you're not really formally diagnosing these people, but I think it's important that you understand the diagnostic criteria that would be applied. The way you go about diagnosing these patients is really no different than any other patient with any other suspected condition or complaint. It really revolves around that triad of history, examination, and laboratory. But by and large, fibromyalgia is a diagnosis of exclusion. You have to rule out a lot of other things before you ever give the person the label fibromyalgia, and unfortunately that often does not occur. And in the history, the first thing we do is sit down and talk to people comprehensively. Sometimes we'll interview them for 30 or 45 minutes, and what we're looking to see is some key things. In fibromyalgia, true classic fibromyalgia, usually their primary complaint is unrelenting, ongoing achiness or pain. And the pain or achiness must be global. By that we mean it can't just be in 1 or 2 or 3 locations. It has to be everywhere, above the waist, below the waist, along the midline of the body, out in the periphery, left side, right side. Because if the problem is a perceptual problem centrally in the brain, it doesn't discriminate on the area of the body where the symptom is taking place. If a person, though, has just localized or regionalized pain, maybe in 1 or 2 or 3 regions of the body, that pain is usually related to an actual structural problem in that area of the body. But in fibromyalgia, it's really a global pain. So it's all over, and it has to be perceived in these softer tissues. It's not uncommon I have someone come in and say, I think I have fibromyalgia. When I ask them where the pain is, they say in my hips, in my ankles, in my knees, in my shoulders. And you very quickly realize the problem is pain in the joints. It's arthralgia. It's not fibromyalgia. We start looking for other things, autoimmune inflammatory arthritis, such as rheumatoid arthritis, ankylosing spondylitis, other types of problems, but it's not a joint problem. And then finally, we're looking for a lot of those other things that I showed on the previous slide on central sensitivity. So do they have some level of depression? Do they have anxiety? Do they have difficulty going to sleep? And when they do sleep, do they wake up afterward and feel unrefreshed? That's classic in fibromyalgia. Do they have a lot of vague gut problems? Do they have things you would associate with irritable bowel syndrome, bloating, gas, distension, constipation, and or diarrhea? Do they have cognitive dysfunction or so-called fibrofog? And do they have persistent ongoing fatigue? The more of those boxes they check, the more it's likely that they really do have fibromyalgia. And also they generally have histories that involve a lot of stress, particularly stress when they were young, during their upbringing, when the nervous system was neuroplastic, and learning how to deal with its environment. So if they had a childhood that was very difficult, maybe they had a rocky relationship with the parent, maybe they had a substance abusing parent, maybe they had, let's say, an alcoholic father who was yelling all the time, may have been abusing the mother, may have been abusing the patient themselves when they were young. It could be verbal, it could be physical, it could be sexual abuse. That's probably the worst form to cause these central sensitivity disorders later in life. But that element of the history is not always there, but it's much more common than it is in general people who don't have these type of problems. Also, these people, from a personality standpoint, tend to be fastidious. They tend to be sort of want to be in control. They tend to be a bit compulsive. They tend to be mother hens, if you will. They're always looking out for everybody around them. They're great caretakers. They feel like something bad is going to happen to somebody at any given time. So they kind of are wired like that in their constitution. And the more you hear those kind of things in the history, the more you're suspicious that this is really a fibromyalgia patient. And the less of that you hear, the more you're a little bit leery of that. From an examination standpoint, we're going to look at that coming up. We need to make sure that the problem isn't something else. It's not a joint issue. It's not a musculoskeletal structural issue. And then from a laboratory standpoint, we're going to look at some things there. But the challenge in the laboratory, especially for conventional physicians, is that there is no fibromyalgia test. There's no box you can check in a lab form that comes back positive or negative, or yes or no, you have fibromyalgia. But there are appropriate tests to do to rule out other organic medical conditions and other things that may be causing the patient's symptoms. Because the differential diagnosis list is very, very long. And this is only a partial list, but we have to differentiate it from true musculoskeletal problems like myofascial pain syndrome and trigger points, from connective tissue and autoimmune inflammatory disorders, whether it's mixed connective tissue disorder, lupus, RA, polymyalgia rheumatica. There are many things. There are also stealth infectious disorders like Lyme and other tick-borne illnesses. Endocrine myopathies or pain in the muscles, fatigue, constipation, all of those things related to something like, let's say, an overt hypothyroidism. You could have multiple problems that are ganging up on you, creating a symptom profile that gets you a diagnosis of fibromyalgia, such as it's not uncommon to see a woman who's iron deficient anemic, therefore she's going to be tired, not going to be making ATP very well, so she goes into anaerobic metabolism, generates a bunch of lactic acid in the muscles ache and hurt, there's not enough ATP to fuel the brain, so there's cognitive dysfunction. So you have a lot of symptoms related to fibromyalgia simply from something like an issue with perfusing the tissue because of oxygen deficiency. And then if there's other things going on that may create some of the other symptoms like depression and anxiety and or gut problems, then often you get a misdiagnosis. But unfortunately, you also have to rule out things like multiple sclerosis, malignancy, small fiber polyneuropathy, and others. But to kind of boil it down a little bit more simply, one of the things we use on intake is a simple pain diagram. And what you see on the left is what you would expect to see in a global pain syndrome like fibromyalgia. You can see there's pain indicated pretty much all over the body, left side, right side, above, below, along the midline, out at the periphery, where on the right you see a diagram where they certainly have pain, and they have pain in multiple areas, but it's much more confined pain. This may be someone with a piriformis syndrome or a gluteal trigger point or a SI joint problem or a lumbar disc problem with radiating pain down the leg, and maybe they also have a problem up in the shoulder complex, infraspinatus trigger point, a rotator cuff problem, a torn labrum, whatever it may be, but it's not a global full body pain scenario, and oftentimes you can pick this up very quickly on pain diagrams. And historically, from an examination standpoint, in the old diagnostic criteria, there were these 18 points you were supposed to check by putting pressure into those points and seeing if the patient had what would be considered an exaggerated pain response. And if anyone out there has studied physical medicine, when you look at these 18 points, it's a bit laughable because these are points that almost everyone hurts in if you mash your thumb into them. The suboccipital muscles that hold your head up all day working on a computer and driving in a car, the upper trapezius muscles and the muscles, in the upper mid-back between the shoulder blades that are very common points of postural stress and very common places for trigger points. Same thing down in the gluteal muscles, same things in the around the elbow, just below the knee on the medial side. These are very common areas of just everyday repetitive stress and strain inflammation that do not have to have classic fibromyalgia to be positive. So there are problems in this tender point examination, and we'll discuss that as well. But using this kind of approach, this original diagnostic criteria outlined by the American College of Rheumatology, it's still problematic in that there's a lot of misdiagnosis of fibromyalgia as a clinical entity, and even rheumatologists are not that great when they study it at differentiating it from various forms of spondyloarthropathy or inflammatory arthritis, connective tissue diseases, and inflammatory arthritis. And in fact, a large-scale study by Fitzcharles, one of the world experts in fibromyalgia, showed that using the formal diagnostic criteria for fibromyalgia, internal medicine doctors, primary care physicians, and even rheumatologists, when they diagnose people with fibromyalgia and then they're referred on to a panel of fibromyalgia experts trained highly in the disorder, and they try to confirm the diagnosis, they can only confirm it in this study 34% of the time, which if you flip that upside down, 66% of the time the diagnosis is incorrect. So about 2/3 of patients diagnosed by physicians with fibromyalgia do not have it. Then when you add in people who may have come to the conclusion that they have fibromyalgia because they went on WebMD, they consulted Dr. Google, or they had their neighbor tell them they had it, the percentage of inaccurate diagnosis or labeling is much higher indeed. Unfortunately, though, many of these patients who are mislabeled get put on fibromyalgia medications, let's say, which really have virtually no chance of helping them and a significant chance of harming them. So as they say, proper diagnosis is half the cure. So getting this issue of proper diagnosis straightened out is really a challenge. And this has been appreciated for a while, and some of the experts sort of advocated getting rid of the tender point exam, partly because they acknowledge that physicians just aren't really good anymore at doing a physical exam and putting their hand on people unless they have physical medicine training, which is kind of a sad statement. So the newer or revised American College of Rheumatology criteria really involves more of a subjective checkbox kind of system, asking the patient if they have pain in different areas of the body, and then asking them about a bunch of other associated symptoms like fatigue, trouble thinking and remembering, waking up tired or unrefreshed sleep, pain or cramps in the lower abdomen, the IBS connection, depression, headache, and then asking questions like, has this been steady and been present at this level for at least 3 months, because it needs to be a chronic disorder to be diagnosed as fibromyalgia, and if they have any other medical condition that might otherwise explain their problems. So this is an attempt to refine, simplify the diagnostic criteria, and it's still subject to massive overdiagnosis of the disorder. And that diagnostic questionnaire should not be confused with another questionnaire that's commonly used, which is the Fibromyalgia Impact Questionnaire, or FIQR. This is not to diagnose it. This is to just simply quantify in some way how much it's affecting the patient's life and everyday activities. And this can be used serially on patients over time to see if they're improving. But sometimes it's mistaken as a diagnostic questionnaire, and it's simply not. Now, medical management, just so you know, is what you would think. It's drug therapy. They've gone through all kinds of drugs through the years. Most of them did not work at all, including anti-inflammatories, including even opioid pain medications do not work in centrally mediated pain like fibromyalgia. The anti-inflammatories don't work simply because, contrary to common opinion, fibromyalgia is not a systemic, overtly inflammatory condition. It is not an inflammatory-driven pain. It's also not, I repeat, not an autoimmune disorder. And most physicians, if you ask them, think it is. It's not. There's no objective evidence at all that it's autoimmune. There's no objective evidence that it's systemically inflammatory. There's generally not elevated SED rates, CRPs, any of the classic inflammatory markers, and anti-inflammatories don't work. However, centrally acting drugs that affect the nervous system and how it behaves can work. The tricyclic antidepressants like amitriptyline, nortriptyline have been used for decades to treat fibromyalgia. It has some benefit in some patients. It's not a panacea, but it did work in some. Now with newer classes of antidepressants, the SSNRIs specifically, which block the reuptake of both serotonin and norepinephrine, that's one of the approved drug classes by FDA for fibromyalgia. The other class of approved drugs is the alpha-2 delta ligands or gabapentinoids, which are basically recycled antiepileptics. So the two approved drug classes by FDA for fibromyalgia were not drugs developed from the ground up for fibromyalgia. They're simply repurposed drugs, repurposed antidepressants and antidepressants. We also, though the original use of antidepressants was because of the acknowledged sleep dysfunction in patients with fibromyalgia, and they gave them tricyclics not because of depression. They gave them tricyclics to help them get into deeper sleep because those medications can do that. And they noticed improvements in other symptoms in addition to sleep, pain, depression, and so forth. But all put together, the medications don't work very well. A big study by RAND recently showed that positive outcomes that are statistically significant in fibromyalgia patients are less than 25%, and the persistence of positive benefit is very poor, so the drug effect wears off. The latest thinking in drug therapy is that the best agents in the drug class, which is of SSNRI, are the go-tos, even though there's admitted poor performance of those. Some of the latest stuff is looking at low-dose naltrexone. Low-dose naltrexone is now being used for a host of different chronic conditions, from autoimmune conditions to various inflammatory issues, to weight loss, to all kinds of things. But low-dose naltrexone seems to work in some of these patients. It has very few side effects because it's used at very low dose in this application. And it does not appear to be working because of its known effect of antagonism on opioid receptors. It's not a pain medication. It actually blocks pain medication. So it's not working as a pain modulator. It seems to be working because it has what's called a pleomorphic effect. It has a bit of a micro anti-inflammatory effect. And that may confuse you because I said fibromyalgia is not an overtly inflammatory condition, and that's true, but there is some newer evidence that there is microinflammation appearing deep within the brain due to excessive microglia activation, which is the immune system of the brain. And things that have this sort of micro anti-inflammatory pleomorphic effect tend to affect this. Vitamin D does that because of its pleomorphic effect. Statin medications can do this because of their pleomorphic effect. But it appears that low-dose naltrexone can do this effectively and safely. But this is very new information, and this may not relate to all patients with true classic fibromyalgia. It may indeed be a subset that have this microglial activation, perhaps due to activation from various metabolites and LPSs and other types of materials that are produced by aberrant gut bacteria and other forms of toxins. We simply don't quite know yet. But what I've done in some of my papers, and I picked this apart in the book as well, is try to split this out into sort of a thinking diagram where if someone comes in with fibromyalgia, they may have it. They may have this classic fibromyalgia, or they don't. They have a false or a pseudo-fibromyalgia. It's a misdiagnosis. And if they're misdiagnosed, they may have other reasons. They may have organic medical conditions causing their symptoms. They may have functional, more subtle metabolic issues. And they may indeed have musculoskeletal issues. So this is a nice little way to map yourself through the thinking process in these patients. But in today's discussion, we're going to really talk about this classic form, the true central pain processing disorder that has sleep dysfunction, has some known issues of sympathetic hyperactivation, some specific changes in neurotransmitters. And what EMG studies, biopsy studies, and other things have shown, excuse me, is that there really is no changes out in the muscle or the tissues that hurt. It's really a perceptual issue in the brain. So if there's nothing wrong in the actual body tissues that hurt, where's the pain coming from? Where is the pain generator? And it is the central nervous system. And if you look at this neurological diagram here, you can see that muscle over there in the lower right. If you stuck a pin in that muscle, you would get a firing from a nociceptive pain receptor. It would fire an impulse through that red neuron. It would come into the back of the spinal cord. It would go through the posterior nerve root into the posterior or dorsal horn of the spinal cord at the innervation level where the muscle was served by the spinal cord. It would synapse right there, or you would exchange little information, one neuron to the next. It would cross the midline and go up through an ascending spinal tract known as the spinal thalamic tract, meaning it stops at the thalamus and then it synapses again and delivers the signal to the area of the cortex of the brain that serves that area of the anatomy in the body so that you can localize or recognize where that stimulus occurred. So if someone sticks a pin in your leg, you know exactly where it happened. You could knock their hand away or pull the pin out. That's because the brain can map where it came from. Along the way, though, there's information derived into secondary pathways such as the spinal mesencephalic tract and the spinal reticular tract. And we're going to talk about the spinal mesencephalic tract in just a moment. This is where these drugs that are approved work. They work centrally on the brain, but they also work down at the level of the spinal cord. The tricyclic and the SSNRI antidepressants tend to diminish the ability of that stimulus to get propagated across that first synapse or that first gateway in the dorsal horn. And they do so by upregulating norepinephrine locally. It seems to have benefit for a limited amount of time in about 25% of the subjects. The other drugs, the alpha-2 delta ligands or gabapentinoids, they work centrally as well in the brain, but they also work peripherally, just even more peripherally. They work in reducing the excitatory ability along that neuron that delivers the signal from the area of the anatomy that suffers the insult. So basically, these drugs dumb down the nervous system. They kind of turn the lights down, if you will, and they create a lot of side effects because of that, like feeling like a zombie, passing your exit on the freeway, not realizing it, along with the other known effects, dry mouth, weight gain. So people don't tend to stay on them very long. It can cause new sensations like burning pain and making someone sleepy all day long, which is the last thing the fibromyalgia patient needs. So when you look at the spinal cord, though, it's really like a little peripheral brain. It has gray matter and it has white matter, and it can learn. It's capable of what's called associative conditioning or learning. It's a very complex thing, and we see this in simple referred pain. A lot of people are aware of referred pain like in a trigger point. When you really have a muscle issue and you have a trigger point in the muscle, if you push on it or have a massage therapist or a chiropractor or a physiotherapist push on it, it'll hurt locally, but if you hold on it long enough, it'll often refer pain into the arm if it's in the upper trap, or up into the head, or down the leg if it's in the gluteal muscles or the pelvic muscles. And that's because of this referred pain phenomena. And that's what's shown on this slide. If you look in the upper right, it says distal muscle. If you stuck that pin in that muscle, you'd have the same thing happen that I showed you on the previous diagram. That impulse would come into neuron 1, shown in black. It would come in the dorsal horn, jump a synapse where it says A there, and then cross the midline and go up to the brain and tell you where it came from. However, if the stimulus is strong enough or persistent or chronic enough, you also get a opening up of what are called secondary pathways or association neurons, shown in red. And if you light up that secondary red pathway, you could see its synapses where it says B. It goes up to the brain, but B sort of exchange area in the dorsal horn shares a final common pathway out to adjacent structures, muscles located nearby, different structures located nearby. So when you get a very acute stimulus or a persistent chronic stimulus, when it gets delivered to the brain can no longer differentiate, did it come from the first muscle or the second muscle, and you essentially get this widening out of the receptive fields of pain. So you can get, regionally, you can get referred pain. But in fibromyalgia patients, this is happening almost throughout the entire spinal cord, and the referred pain area basically becomes the entire body. So it's a very, very difficult condition indeed. And one of the chemicals that mediates turning on those association neurons is a pain-modulating peptide known as substance P. We know that there's much more substance P in the cerebral spinal fluid bathing the brain and the spinal cord in patients with true global pain syndromes like fibromyalgia. And this is the last neurological diagram I'm going to show you, trust me. But it's really important to make a point here in that there's a system that stops this from occurring normally. It stops things from becoming a runaway train. So if you look down at the bottom of this diagram on the right where it says nociceptor, consider that a muscle where you stick a pin in. You have coming back through that neuron that's shown in red, the stimulus, crosses the midline and the dorsal horn, goes up the ascending track and delivers it to the thalamus and ultimately to the cortex, so you know where the problem or the stimulus came from. But it also, there's that secondary track again, the spinal mesencephalic tract. It also delivers the information to the mesencephalon, where the mesencephalon in turn transfers the information to now a descending spinal tract that goes downward. And this happens in the area called the paraequeductal gray matter. It stops off and transfers the stimulus in an area of the medulla called the nucleus raphe magnus. And then it finally sends the final stimulus back down to that exact area of the spinal cord where the insult came in with a suppressive stimulus that turns off the circuit. So the initial insult opens the gate or turns on the circuit, delivers the message to the brain, and then this descending antinociceptive system shown in red shuts the gate or turns the system off. And this is very important, and I can make this practical for you. When you put a shirt on in the morning, when you get out of the shower, you realize that you didn't have a shirt on before and you have a shirt on now. You know, a couple minutes later, you don't still realize you have a shirt on. Your nervous system isn't telling you all day long you have a shirt on, you have a shirt on, you have a shirt on. It's useless information, it would drive you crazy, and it's not a threat. So the descending antennoceptive system turns that off. This is failing in people with fibromyalgia. Failure of the DANs is considered a major cause of classic fibromyalgia, or at least part of the dysfunction. And basically, they open up all their circuits all the time, and they never shut them down. So you get an amplification effect. So things like light touch are perceived as pain, for instance. And we can see this in the brain. This sort of global pain looks very, very different and involves deeper centers of the brain, more emotional, affective centers of the brain versus discrete localized pain. And this descending antennoceptive system is really keyed by the limbic system via the hypothalamus, and serotonin is the main messenger here. So when the limbic system is dysfunctional, you basically start seeing all of the problems in the nervous system that are related to fibromyalgia. Hypervigilance, sleep disorder, irritable bladder, irritable bowel, irritable everything, failure of the DANs, increased cortisol, ACTH, adrenaline or catecholamines, increase in the HPA axis stress response, and that's what you have. So this is really sort of a variant of limbic system dysfunction. And we know the chemistry, we know that there's deficiency of serotonin and increase in substance P. Deficiency in serotonin is problematic on a multitude of levels. It drives the HPA axis, alters substance P levels and pain perception, and initiates stage 4 sleep. So these patients who are serotonin deficient get into this scenario of a lot of pain, poor sleep, fatigue, and stress, which causes more pain, more poor sleep, more fatigue, more stress. So it's a feed-forward cycle. So, and in fact, specific types of sleep dysfunction may be the most objectively quantifiable abnormality seen on true classic fibromyalgia patients as a diagnostic tool. And because there's a very specific type of sleep dysfunction in fibromyalgia, it's called alpha wave intrusion. So when you should have delta wave activity, so sleep is divided up into these 5 stages, alpha, theta, 2 deltas, and a REM sleep or REM sleep. Fibromyalgia patients do not go into deep delta stage 3 and 4 sleep very well, and that's the time of sleep where you get restoration, you get rebuilding of the tissues, and you get refreshed. So they wake up unrefreshed. They can sleep 14 hours, but they can't sleep their fatigue and pain away because they never get refreshing sleep. They have alpha waves when they should have delta waves. And you can see that you don't spend the majority of your time in delta wave sleep, but it's a really important, in fact, the most important time during sleep. And this alpha wave intrusion has been quantified by multiple researchers, first by Harvey Moldovsky at the University of Toronto. And if you look at our modern Western world and you look at what causes our sleep dysfunction, well, ambient light is one of them. This is the globe from space, and you can see where we live is all lit up like a torch, and the rest of the world, not so much. So consider this from an evolutionary perspective, this is relatively new, and being exposed to all of this blue spectrum light all the time, even when we think it's dark, it's not. And particularly being on things like electronics and screens and devices into the evening is very disruptive to our sleep. So in these patients, we use different apps and software packages that pull the blue spectrum light out of their displays as it gets later in the day. You can use amber lenses that block blue light, which disrupts melatonin production in sleep. And amber lens therapy does work in helping sleep quality and decreasing global pain. So we can probably assume that Bono does not have much of a sleep problem or fibromyalgia, but I don't know that for sure. But there are many of these different kinds of apps out there, and they're very, very useful, and we use them effectively. We also tend to change the lighting in people's rooms that they're in the evenings to use very specific blue blocking lights or at least light bulbs that go into existing fixtures that block blue light. And this is very, very effective. If you look at the flat-lined line on the bottom with the circles, unfilled in circles, that's the melatonin production of a lot of people who keep being exposed to light all the time. And then if you use goggles, dim lights, and things like that, you can restore the melatonin output at night, which can help them sleep better. So good sleep hygiene, to bed by 10, up by 7, limit the bright blue light and electronics 3 hours before bedtime, quiet, dark, comfortable bedroom situations, no big pets in the bed, no reading, no TV in bed, 2 things only in bed, sleep, and you can guess the other. If not, get out of your bedroom. Prayer, progressive relaxation, yoga, mindfulness meditation, all of those kind of practices in the evening are very good. So we train our patients on how to do that. And we can also use things like sustained release melatonin. We can use GABA or pharma-GABA, GABAergic botanicals, valerian, passiflora, melissa, German chamomile, theanine, inositol, magnesium threonate, and 5-HTP to help from a chemical standpoint. And that can also help with global pain because 5-HTP as a serotonin precursor can be very effective in pain modulation, helping sleep, and getting serotonin levels up effectively, even where the drugs sometimes fail, because the drugs depend on you making at least a baseline level of serotonin to block the reuptake of. Sometimes these people need precursor therapy. And you might have to work with a physician who can look at the lab test and can work with this, particularly if they're already on some sort of serotonin modulating medication. But we know if their serotonin is deficient, their substance P in the cord will go high, which can lead to increased pain perception. So we use serotonin modulators to our advantage, 5-HTP, melatonin, some of the other things we talked about, or drugs at times in certain people. But stress and anxiety management techniques, cognitive behavioral therapies, some of these calming botanicals and nutraceuticals. And treatment with 5-HTP has been well studied, head-to-head comparisons with antidepressant medications, and it's very, very effective. In fact, as effective as tricyclic or MAOI antidepressant classes of medications. We often turn to organic acid analysis to look at serotonin metabolites like 5-HIAA to guide our therapy here. And to boil it down, this is some of the things we commonly use in classic fibromyalgia patients. 5-HTP therapy at intervals throughout the day with a final dose right before bedtime with sustained released melatonin. We also look at vitamin D, because if vitamin D is not right, you will not convert 5-HTP to serotonin effectively because it affects the tryptophan hydroxylase enzyme. We look at the GI microbiota, particularly if there's a lot of GI complaints, because the wrong kind of bacteria in the gut can chew up all your dietary tryptophan, depriving you of tryptophan to make serotonin. It can produce enzymes that'll degrade tryptophan. It can also do the opposite. You can have dysbiosis patterns that produce too much tryptophan or too much even 5-HTP. So we look at that with more molecular-based stool technologies when we need to. But the other thing we keep an eye on is catecholamines out of the adrenal medulla. We look at the metabolites of epinephrine, norepinephrine, the sort of fight-or-flight adrenaline hormones, because we need to calm that down. These patients have a neurological pattern that is very much like overt post-traumatic stress disorder or what Mold has described as distressing life events. Sometimes they have those in their history, sometimes they don't, but regardless, they are locked in this sustained fight-or-flight, sympathetic dominant hypervigilance type of pattern, which is creating irritable everything. So, and studies have shown you can stress people out enough and induce allodynia, which means pain all over the body. You can also deprive them of sleep and induce pain and allodynia, and you will increase their dopamine, a catecholamine, and you will decrease their melatonin. These are the exact patterns we see in classic fibromyalgia. So not only the cognitive behavioral therapy stuff, but we use things that are calming, including adaptogens, but only adaptogens that are calming. We don't use stimulating adaptogens. Most adaptogens are stimulating. like Panax ginseng, eleuthero, rhodiola, licorice. We do not use those. We use calming adaptogens like ashwagandha with Ania somnifera, right, somnolence, but also GABAergic calming botanicals, German chamomile, valerian root, passion flower, lemon balm, and others, along with calming nutrients and nutraceuticals, theanine, taurine, phosphatidylserine, GABA, magnesium threonate, and just things that are depleted by stress that help the adrenal glands, vitamin C, various B vitamins, so forth. But cognitive behavioral therapy is really the final piece of it here. We will use real-time biofeedback in our office, doing brain mapping, training them to get into more calming brain states and getting better at doing that. And then we usually we'll map, and this is one of my practice partners, Adam Briner, who's a specialist in brain mapping. He's mapping my young son, my 8-year-old Owen, because he fell in hockey and had a mild concussion. So we were able to see exactly what areas of the brain were affected by the concussion and help him in recovery with hyperbaric oxygen, IV glutathione, and other things that were really helpful. And because of that experience, we then mapped my older son, Ian, shown in blue, so that we had a baseline on him, because he's sort of into athletics too, and it's only a matter of time before he bangs his head. So at least we have a baseline on him. We also use heart rate variability and train the patient how to do that with little apps that they could get on their mobile devices that are very, very effective at training them to be less stressed out within the nervous system. We can hopefully get them mindfulness meditation or some form of stress relieving activity, and there's great objective medical literature on this. Sometimes we get them into therapy with counselors that do forgiveness therapy. They do things to sort of deal with past traumas and the like, if that's in their history. And just as a quick review, this thing called fibromyalgia is a very complex disorder with limbic system activation, commonly previous trauma and stress that change limbic system activity over time, HPA activation, hyperpersistence of the stress response in the sympathetic dominant stance, and what's called hypervigilance, synaptic excitation in the association neurons in the cord and in the brain, failure of the descending antennoceptive system to control that dysfunction, overall central sensitization, increases in substance P, decreases in serotonin. And in the medical literature, the things that have the most A-level data at helping these patients is mild, I stress, aerobic exercise, gentle stretching and movement, cognitive behavioral therapy, and modulation of serotonin either through precursors or antidepressant medication. There's some promising evidence with hyperbaric oxygen and other types of therapies. And this is a more granular version of that diagram I showed you earlier that's from some of my publications that helps you kind of frame this up. And I just wanted to end on, I didn't have time to go into the pseudofibromyalgias, but the three most common, what we call masqueraders of fibromyalgia, things that get you diagnosed with fibromyalgia if you're a woman when you don't have fibromyalgia. There are many, but the top three are an underappreciated, undetected, suboptimal thyroid gland. So it doesn't have to be in-your-face overt hypothyroidism that would be diagnosed by your family physician on just a TSH test, but sometimes you have to look more granularly. You have to look at T4, T3, free T3, free T4, or reverse T3. So you have to get into that or really find a physician who really understands that, could optimize thyroid function. And sometimes that's all it takes, because that can cause a lot of problems associated with or thought to be fibromyalgia. Another one is myofascial pain syndrome. These are actual muscular problems. You have to put your hands on the patient. A physical medicine provider is really good at this stuff. So this is where the patient does benefit from massage, body work, chiropractic, physiotherapy, acupuncture. Most fibromyalgia patients who have true classic fibromyalgia fail with those therapies because their problems are not in the somatic tissues. But those who have myofascial pain syndrome, which is a lot of them because it's a big point of misdiagnosis, do much better with that. And then suboptimal energy production at the level of the mitochondria. Just some pearls, clinical pearls to take away. Herbal nutritional strategies for someone who really does have tight muscles. They truly have myofascial pain syndrome, not fibromyalgia. things like magnesium, calcium, but valerian root, passion flower, hops, kava, all great natural muscle relaxers and cognitive behavioral therapies. And then mitochondrial support would be things like CoQ10, L-carnitine, D-ribose, lipoic acid, nicotinamide riboside, PQQ, botanicals for mitochondrial biogenesis like resveratrol, curcumin, green tea, and so forth. And then if you really want to look at this a little more granularly, I really would encourage you to read the book. This is a sort of algorithmic clinical diagram on how to work you through the whole diagnostic and thought process in working up a patient with fibromyalgia, particularly for people to share with their physicians. You can find many of these diagrams and learn more on my website, drdavidbrady.com, or on fibrofix.com. There's links out to full text of many of my previous medical journal articles, which some of these diagrams originally came from, and a great interview in the Townsend letter done. That's a very easy read that summarizes and goes into more detail on what I did today. And hopefully, with this information, you can change this experience more into an experience that would be depicted like this on pictures, helping people get back to the vibrant life that they really deserve to have. I would encourage you all to pick up a copy of the FibroFix book. You can get it on Amazon, Barnes & Noble. You can just hit the fibrofix.com website and hit the book tab. You can launch out to any of those sites to buy the book if you'd like to. There's a lot of discounts on it online right now at those vendors. But pop back, put in your receipt code, and it unlocks a whole bunch of other educational bonuses and interviews and things like that. You can also still access the FibroFix Summit, which ran in June, and I interviewed over 35 experts on the topic. You can get digital access to that as well, and that's just a master course essentially. So just go to fibrofix.com and you can learn more about that. And with that, I know I ran a little bit late, but I'm happy to stay on and answer some questions for anybody.
Excellent. Thank you, Dr. Brady. That was fantastic. I just want to ask you, it sounds like, one of the most important aspects when you're working with patients who you suspect might have fibromyalgia, the history sounds like it's very important. Do you see a strong correlation of fibromyalgia with adverse childhood stress or trauma inhibiting the ability for the body to heal? And how long does it take for you, once you start working with a client and they're complying with your protocols, how long does it generally take to get somebody, I don't know if the right word is remission or healed from the disorder, but what is about the time frame when someone can expect to start feeling better?
It's a very good question, and I wish there was a nice, tight, very discrete reductionist answer to it. Unfortunately, there's not. I'll start with the first element of the question, which is, yes, there's a much higher correlation with adverse, life events and distressing events in childhood in patients with fibromyalgia than normal. I hate to say normal people, or people without fibromyalgia. It's not something that absolutely has to be there in every single case, but it's there a lot more than it's not. And sometimes when it's not, it's a matter of non-disclosure on the part of the patient, or even suppression of it. And so it's very difficult because it's deep-seated, it's rooted in the past, and as the great book, The Body Keeps the Score talks about at length. These are patterns that are locked in when the nervous system is very young, it's very neuroplastic, and it's learning how to behave. And once it has these long-term structured patterns that involve the limbic system and amplification and hypervigilance, it's not easy to turn around. You have to hit it from all fronts. And the book gives a really mapped out plan of doing that. And, it really starts with sort of a 21-day metabolic reboot. It's sort of a metabolic detox, mitochondrial support, getting off all inflammatory things and all the bad foods and all of that. And it's not a cure for fibromyalgia. It doesn't go directly at fibromyalgia. It's simply laying the groundwork and setting the stage for a healthier individual overall that's ready to then engage in the deeper types of therapy that are required while they're reading the book and trying to figure out, first of all, what is fibromyalgia, right? What is it not? Do I really have it or not? And if I do have it, what are things I can do about it? But if I don't seem to have it, what are the other things it might be? And then there are solutions offered in all of those different variants or buckets, if you will. And, so while they're doing this 21-day sort of reboot, they're figuring out what category do they fall in. Do they fall in classic fibromyalgia? Are they more of a structural issue? Are they more of a metabolic functional kind of a problem? Or do they have a musculoskeletal issue, whatever it may, or do they have an organic medical disorder? And I give routes to pursue based on that and solutions. They're dietary, they're nutraceutical, they're botanical. There's a lot of advice on medications, but part of that first even 21-day program is not just the biochemical sort of detox stuff. It is regaining motion and movement in a very safe, systematic way that ramps them up. They have to start moving and getting mobility. So there's instructions, there's pictures, there's all the things you need to do that safely. And then you need to start engaging in these sort of cognitive behavioral therapies, these calming, neurologically retraining the nervous system to react not only to stress, but in their case, even everyday sensory information and stimulus to react in a very, very different way. And that's a really important thing. And depending on how deep-seated the dysfunction is and how severe the case is, it will vary on how much they improve, how quickly they improve. But generally, within the course of a month or two, they're feeling significantly different and on the better side if they have true classic fibromyalgia. And that's the much harder thing to treat. But remember, the vast majority of these patients will not have classic fibromyalgia. They will have one of these other things. Many of those are very easy to treat and turn around very quickly if you identify it right and treat it right. I mean, if it's underperforming hypothyroid kind of situation, you fix the thyroid and get that running right, get the metabolic set point correct, they're better in a week to 2 weeks. You just got to identify it and treat it. If it's an energy mitochondrial issue, you can turn that around pretty quickly too, unless there's an underlying factor like a genetic mitochondriopathy or a persistent heavy metal toxicity or something that takes longer to deal with. But so it really varies on how quickly they get better, depending on what's actually wrong with them in the first place.
Right. And you have to really stick with it and be a detective.
You do.
Yeah.
This is not a disorder that we're too used to and too kind of reliant on wanting what's the protocol, right? Someone comes in and says, I have X. You assume they really have X, and you give them, X, Y, Z, nutrients. It just doesn't work like that in this disorder. Unfortunately, it's not that easy. It's not that simple.
Yeah.
It's something that you have to just work through and sometimes, I have to work with a team of people. I have a good counselor, that works with people who need that. I have a cognitive behavioral therapist that will, show people how to do guided imagery, biofeedback, how to do heart rate variability. That's all really, really important if you really want to comprehensively manage these more difficult cases.
Right. Oversight and specialists to refer out.
But, the book was written from the standpoint of what can the healthcare provider do, whether they're, nutritionist, physician, it doesn't matter. And what can the patient do? I mean, because when it all comes down to it, any of these chronic disorders, you can't fix them. The patient has to engage in their own recovery. They have to do things. They have to change things. They have to make lifestyle modifications. They have to change the way they think about their disorder. They can't be in defeatist chronic disease mentalities. There's a lot of things that need to be done, and the book is meant to empower patients to start making those changes, to start doing those things, and it kind of guides them on when they really need to get a doctor involved and what kind of doctor to try to find and how to find them. But I think a lot of them would do great by following sort of that protocol, by working with a nutritionist or a life coach or someone like that who can actually spend that extra time and provide that extra level of care and support to them that sometimes the doctors just don't do or can't do.
Right, right. That's perfect. Well, and thank you for offering this book, the Fibro Fix, and your contact information that we all have in front of us. Thank you so much, Dr. Brady. We're going to close for today. This information was fantastic. We appreciate your joining us and your support.
Thank you. And then the book is really full of a lot of direct nutritional advice and interventions, and so are a lot of the other papers and stuff if you visit fibrofix.com. So I hope you can, that's a good point of information to augment that specific area of it. So
yeah.
Thank you.
Yes, thank you. Thank you so much, Dr. Brady. Have a wonderful afternoon.
Okay.
All right.
Okay, you too. Bye-bye.
Bye-bye.
Thank you, everybody.
All right. Thank you, everybody, yes, for attending. And a recording of today's broadcast will be sent out within the next 24 hours. If you have questions for our guests or for me, please let me know at shannon@nanp.org. And also want to remind you, next month, Thursday, October 13th, Justin Crane, who is a certified financial planner and personal strategist for your business, will offer some seriously simple strategies to help you increase your business revenues. So mark your calendars for Thursday, October 13th, and we'll meet up again for another educational and inspirational hot topic scoop webinar. Have a great rest of your day.